4 men walked into the same urology practice within 1 month. All had PSA results in the 4 to 10 range. The gray zone, where PSA is elevated but not clearly diagnostic, where decisions are hardest, where mistakes happen most often. Man A, PSA 4.2. Just barely elevated. His doctor said, "Let's watch and wait. No further testing. Annual monitoring only." 2 years later, PSA jumped to 9.8. Cancer found on biopsy. Stage 2. Treatable but more advanced than it should have been. The mistake, waiting too long in the gray zone without proper risk assessment. Man B, PSA 7.5 mid-range gray zone. His doctor said, "We should biopsy immediately." 12-core biopsy performed. Results? No cancer, just inflammation. 6 months later, PSA dropped to 5.1 with anti-inflammatory treatment. The mistake? Jumping to biopsy without evaluating other factors first. Man C, PSA 9.1 upper gray zone. His doctor said, "Let's do MRI first, then decide." MRI showed suspicious area. Targeted biopsy performed. Cancer found. Grade group 2, caught early, excellent prognosis. This was the right approach. Proper evaluation before intervention. Man D, PSA 5.8 mid-gray zone. His doctor ordered additional biomarkers. Prostate Health Index, 4K score, free PSA percentage. All came back low risk. MRI performed, no suspicious areas. Decision, active surveillance with close monitoring. 2 years later, still no cancer. PSA stable. This was also right approach. Comprehensive evaluation prevented unnecessary biopsy. 4 men, 4 PSA levels in gray zone. 2 got optimal care, 2 did not. The gray zone is dangerous not because of the numbers themselves, but because it's where uncertainty leads to either overtreatment or undertreatment, where doctors make rushed decisions, where patients panic and demand immediate answers, where insurance companies pressure for definitive testing. Today, I'm revealing how to navigate the PSA 4 to 10 gray zone, the additional tests that clarify your risk, the decision framework that prevents both mistakes, and why this range requires the most careful evaluation, not the least. If your PSA is anywhere from 4 to 10, you're in the zone where navigation matters most. This video is for education only, not medical advice. Always work with your doctor on PSA evaluation and treatment decisions. This is about understanding the gray zone, not self-diagnosing. Individual situations vary. Before we start, comment gray zone below. I'll send you the complete gray zone evaluation checklist with all tests and decision points. Takes 2 seconds. Now let me show you why PSA 4 to 10 is the most dangerous range. PSA 4 to 10 is called the gray zone for specific reason. Below 4, generally considered normal for most men. Above 10, generally warrants immediate additional testing. Between 4 and 10, genuinely uncertain. About 75% of men with PSA in this range do not have cancer, but about 25% do have cancer. The number alone can't tell you which group you're in. This creates the danger. Some doctors treat everyone the same. Immediate biopsy. This leads to 75% unnecessary procedures. Other doctors wait on everyone. Annual monitoring only. This leads to 25% delayed diagnoses. Both approaches create significant problems. The gray zone requires individualized risk assessment, not one-size-fits-all responses. Let me show you how the 2 men who got optimal care were evaluated differently from the 2 who didn't. Man A had PSA 4.2, just slightly elevated. His doctor said, "Let's watch it annually." Seemed reasonable, conservative approach. But his doctor never evaluated other risk factors. What they should have checked: family history. Man A's father had prostate cancer at age 62. Age: Man A was 54. Young for elevated PSA. Free PSA? Never tested. This would have shown 8%, very low. Concerning. Digital exam felt normal, but exam alone isn't enough. PSA velocity. Previous PSA was 3.1 2 years ago. Jump of 1.1 in 2 years. Rapid. If his doctor had evaluated these factors, the risk profile would have been clear. Young age, family history, low free PSA, rapid velocity. This combination warranted additional testing immediately, not waiting 2 years. By the time PSA reached 9.8, cancer had progressed, still treatable, but more aggressive treatment needed. The mistake wasn't choosing surveillance over biopsy. The mistake was choosing surveillance without proper risk assessment. Gray zone PSA requires stratification, not assumption. Man B had PSA 7.5, mid-range gray zone. His doctor said, "That's elevated. We should biopsy." Standard 12-core transrectal biopsy scheduled. No additional testing first. No MRI. No biomarkers. No risk assessment. Just PSA 7.5 equals biopsy. The procedure found no cancer, just chronic inflammation. Man B experienced significant anxiety before procedure, pain and discomfort during procedure, blood in urine for a week after, blood in semen for a month, infection risk. Fortunately, no infection, but risk was real. All of this could have been avoided if his doctor had ordered free PSA test, would have shown 28%, very reassuring. Prostate MRI would have shown no suspicious lesions. These two tests together would have indicated low risk. Surveillance would have been appropriate, biopsy unnecessary. 6 months later, PSA dropped to 5.1 with anti-inflammatory approach, confirming it was inflammation, not cancer. The biopsy added no value, just complications and anxiety. The mistake wasn't being cautious about PSA 7.5. The mistake was skipping stratification and going straight to most invasive option. Man C had PSA 9.1, upper gray zone. His doctor said, "Let's get complete picture before deciding." Step 1. Additional blood tests. Free PSA, 11%, low. Concerning. Prostate Health Index, 48, elevated, concerning. Step 2. Prostate MRI. Showed PI-RADS 4 lesion in peripheral zone, suspicious. Step 3. Targeted biopsy. MRI guided biopsy of the specific suspicious area. Results: cancer found. Gleason 3+4, grade group 2. Step 4. Treatment discussion. Cancer caught early, multiple treatment options available. Active surveillance, surgery, or radiation all viable. Patient chose surgery. Excellent outcome. This systematic approach worked because high-risk biomarkers warranted MRI. Suspicious MRI warranted targeted biopsy. Each step informed by previous step. No unnecessary testing. No delayed diagnosis. Optimal pathway through the gray zone. Man D had PSA 5.8, mid-gray zone. His doctor said, "Let's determine your risk level comprehensively." Step 1. Clinical evaluation. Age, 69. PSA elevation expected with age. Digital exam, enlarged but smooth. No nodules. Family history, none. Symptoms, moderate urinary frequency, consistent with BPH. Step 2. Advanced biomarkers. Free PSA, 26%, very reassuring. Prostate Health Index, 18, low risk, 4K score, 8% probability of high-grade cancer, low. All 3 biomarkers aligned, low risk. Step 3, prostate MRI, no suspicious lesions identified. Uniform enlargement consistent with benign prostatic hyperplasia. Step 4, decision. All factors pointed to low risk. Recommendation, active surveillance. PSA monitoring every 6 months. Annual MRI, no biopsy unless risk factors change. 2 years later, PSA ranges 5.4 to 6.2, stable, no cancer detected. He avoided unnecessary biopsy while maintaining appropriate vigilance. This worked because comprehensive low-risk profile was established before deciding against biopsy, not assumption. Evidence-based decision. These 4 cases teach us the framework for navigating PSA 4 to 10. Step 1. Clinical risk assessment age. Younger men with gray zone PSA higher concern. Family history. First-degree relatives with prostate cancer increases risk. Ethnicity. African American men at higher risk. Symptoms. Urinary issues help distinguish BPH from cancer. Digital rectal exam. Hard nodules concerning. Smooth enlargement less concerning. Step 2. Biomarker testing free PSA percentage. Under 15% concerning. Over 25% reassuring. Prostate Health Index. Combines total PSA, free PSA, and 2 pro PSA. Score over 35 concerning. 4K score. Estimates probability of high-grade cancer. Over 7.5% concerning. PSA density. PSA divided by prostate volume. Over 0.15 concerning. Step 3. Risk stratification low risk profile. Reassuring biomarkers, normal exam, no family history, older age. Approach. Active surveillance with close monitoring. High risk profile. Concerning biomarkers, abnormal exam, family history, younger age. Approach. Proceed to imaging. Step 4. Imaging. If indicated, multiparametric prostate MRI identifies suspicious lesions. PI-RADS scoring 1 to 2 low suspicion, 3 to 5 higher suspicion. If suspicious lesion found, targeted biopsy. If no suspicious lesion, surveillance or consider systematic biopsy based on other factors. Step 5. Informed decision biopsy decision based on complete profile, not PSA number alone. Surveillance decision based on evidence of low risk, not assumption or hope. Man A. Surveillance chosen without establishing low risk profile. Should have had biomarkers and imaging before deciding to wait. His high risk factors would have been identified. Earlier intervention would have caught cancer at better stage. Man B. Biopsy performed without establishing high risk profile. Should have had biomarkers and imaging before deciding to biopsy. His low risk factors would have been identified. Unnecessary biopsy would have been avoided. Both mistakes came from treating gray zone as if it were black and white. Either watch everyone or biopsy everyone. The gray zone requires nuance. If your PSA is between 4 and 10, don't panic. Most men in this range don't have cancer. Don't assume you're fine. 25% do have cancer. Instead, get complete risk assessment. Talk to your doctor about free PSA testing if not already done. Consider Prostate Health Index or 4K score. Digital rectal exam if not recently performed. Prostate MRI if biomarkers or exam raise concern. Calculate your PSA density if prostate volume known. Review family history and other risk factors. The goal? Determine if you're low risk or high risk within the gray zone. Low risk, surveillance appropriate with close monitoring. High risk, additional testing warranted, possibly biopsy. The gray zone isn't dangerous if navigated properly. It's only dangerous when treated simplistically. Man A. Waiting without risk assessment led to delayed diagnosis. Man B. Biopsy without risk assessment led to unnecessary procedure. Man C. Systematic evaluation led to appropriate early cancer detection. Man D. Comprehensive low-risk confirmation led to avoiding unnecessary biopsy. The difference wasn't luck, it was approach. 2 doctors used evidence-based stratification. 2 doctors used assumption-based decisions. The gray zone punishes assumptions. It rewards systematic evaluation. If you're in the PSA 4 to 10 gray zone, you're in the range where approach matters most. Not too low to ignore, not too high for automatic intervention. Right in the middle where decisions determine outcomes. Get your complete risk assessment. Don't let your doctor treat you the same as everyone else in this range. Your individual factors determine your individual path. Comment gray zone below for your complete evaluation checklist showing every test and decision point for PSA 4 to 10. Subscribe for next week's video on the specific biomarker tests that have highest accuracy in the gray zone. 4 men, same gray zone. 2 got optimal care through systematic evaluation. The same systematic approach could guide your path through uncertainty.